Good afternoon, everyone. My name is Deborah Levine. I am your Community Engagement Officer for the City University Graduate School of Public Health and Health Policy. It gives me great pleasure today to introduce the rising rates of congenital syphilis access to care. This is part 3 of a 3-part series. Welcome, everyone. And to get started, we'd like to thank our partners, the National Black Women's HIV/AIDS Network, Community Boards 9, 10, and 11, and 12, Haven Midwifery, Sigma Gamma Rho Sorority, the Alumnae Chapter of Manhattan, Sisterlink, Northern Manhattan Perinatal Partnership, also our City University School of Public Health Sexual Reproductive Justice Hub, the Cultivated Community Foundation, Mixxy's Blossom, and all of you. Really quickly, some housekeeping. Today we'll be using the Q&A function, which you'll find at the bottom of your toolbar. If you don't see it at the bottom of your screen, just take your indicator and move it around and the toolbar will come up. If you still don't see it and you see the word more, please click there because the Q&A function will come up. Please know that all of your questions we will be keeping so that we can make sure that we answer, but all of your submissions will be anonymous unless you so identify. Only the presenters and the hosts will see your questions, so please feel free to ask anything. We're happy to answer any questions. Today's agenda for the webinar, as I've introduced myself as the director of the Harlem Health Initiative, happy to have you all join us. We have a presentation today by Dr. Betancourt from the New York City Department of Health and Mental Hygiene. Also, we have our favorite Sisterlink Collaborative with us here. Dawn will be helping us navigate through the conversation and also the Q&A. Once the presentations are finished, we will enter into our Q&A period, and we encourage you to please, even as the presentation is going, to drop your questions, your concerns, or your comments in the Q&A, which will then be followed by the key takeaways. So this is part of our Black Maternal Health Week events, #BMHW24. This week is held usually between April 11th through the 17th. It's Black Maternal Health Week. It's a week-long campaign that was founded and led by Black Mamas Matter Alliance to build awareness, activism, and community building to amplify the voices, perspectives, and lived experience of Black mamas and birthing people. This year's theme is Our Bodies Still Belong to Us, Reproductive Justice Now. So just to give you a little stats on Black maternal health nationally and the reason why we are raising this conversation in 2021, maternal mortality rates for non-Hispanic women, Black women, was 69.9 deaths per 100,000 live births, which makes that 2.6 times the rate of non-Hispanic white women. In the US, Black women are 3 times more likely to die from pregnancy-related causes than our white counterparts, so noted by the CDC. That more than 80% of pregnancy-related deaths are preventable. That's 80%, just to be clear. Nationally, in the US, 29 to 44% of Black women experience postpartum depression symptoms, yet are rarely even identified or connected to mental health care. Postpartum depression symptoms are also noted as PDS. Here in the state of New York, Black, non-Hispanic women have a pregnancy-related mortality ratio 5 times higher than white women and non-Hispanic women. 54.7 versus 11.2 deaths per 100,000 live births. And you can see this data in the New York State report on pregnancies associated to deaths in 2018 to 2020. I think this stat is, and this graphic is the one that sits the hardest for me. Pregnancy-related deaths in New York City, and we're talking about New York, the 5 boroughs. 60% of pregnancies associated deaths in New York City between 2016 to 2018 were preventable. Yeah, it's horrible. So I would like at this point to decrease so that I can make sure that we have plenty of time to hear from our presenter today, Dr. Betancourt, from the New York City Department of Health and Mental Hygiene.
Syphilis cases among women. The New York City Department of Health and Mental Hygiene designed a project to reduce syphilis among Black and Latina cisgender women of reproductive age in the New York City neighborhoods most heavily impacted by the primary and secondary syphilis case rates. And we did this, we're doing this from funding through the National Association of City and County Health Officials, or NACHO. The goals of this project overall are to really build community connections in order to address these increased rates and facilitate and support a community developed plan to reduce syphilis focused on this prioritized population of Black and Latina cisgender women. And what we're hoping is that through this project, we can really increase meaningful and responsive engagement of community in partnership with the health department to prevent syphilis among Black and Latina cisgender women. Next slide, please. So this just kind of gives you an overview of the reported primary and secondary syphilis case rates on the left, utilizing a map of New York City and its 5 boroughs, and then on the right, the early latent syphilis case rates per 100,000 in the population by zip code and zip code of residence in 2022. And what we're seeing is that unfortunately, the majority of the case rates are in areas of the city that are already experiencing disproportionate and inequitable health conditions. So we're seeing parts of the Bronx, particularly in the South Bronx, parts of Upper Manhattan, including Harlem. We see also areas of Brooklyn, such as Brownsville, East New York, and East Flatbush, as well as Jamaica, Queens, having a high burden of the case rates. Next slide, please. And this just kind of gives you a historical overview of case rates among 100,000 in the population over time in New York City from 1940 to 2022. And so what you see is that the cases over time peaked and sort of plateaued in part, like, so when we look in like the early between 1940 and 1944, and you start to see that decline, that's related to when penicillin was introduced as treatment for syphilis, right? It's a bacterial sexually transmitted infection. We see some changes over time, for instance, around 1960, where we start to see some increases again. We can see that that might be in part due to the introduction of the pill, the oral contraceptive, in the society, and so that may also have led to some changes in behavior, right? In the society and the population. We're also seeing peaks starting in the 80s, and then over the following decade or so, a dramatic decrease. That might also be related to the HIV/AIDS epidemic, and again, changes in the way that society overall may have been behaving in terms of sexual practices. Where we're seeing like an all-time low around 2000, so about 2 decades ago, there was a thought that maybe syphilis could have been or could be eradicated. But we start to slowly see some increases. And in part, that may have been due to the release of PrEP, pre-exposure prophylaxis for HIV. And again, thinking about how on a societal level, maybe behavioral changes in sexual practices where folks may not have been using condoms as much as they were before. The important thing to understand with this is, again, this is overall a societal picture. It doesn't really point to any one particular causal factor. And it doesn't really take into account the full array of social and structural factors that often are related to health outcomes. Next slide, please. So this gives you a breakdown of primary and secondary syphilis case rates on the left by borough. And so what you see are that the case rate is highest in Manhattan, that's the yellow line at the top, at almost 42, compared to the citywide rate, which is the aqua light blue, at almost 27. After Manhattan, we see that the highest rate is in the Bronx. And then on the right, what we see is that the case rate in early latent syphilis over that same time period. And what we're seeing again is that the highest rates are found in Manhattan, with a slighter dip in 2022, where we see that the Bronx slightly surpasses. And again, this is in comparison to the citywide rate at 52.9. Next slide, please. Again, for the purposes of this presentation, I really wanted to highlight and elevate what this all means for women, right? So we know that the largest portion of cases are among persons reported as males or men. However, the focus of this presentation is really, again, to highlight how this is affecting women. And what we're seeing is that even though rates for men have sort of plateaued, they're starting to rapidly increase for women. And we see that there's striking inequities by race and ethnicity. So in 2022, Black and African-American females or women had a case rate of 12.09 per 100,000 in the population, compared to the citywide rate of 5.7, so almost double. Hispanic and Latina females had a case rate that was a little bit above the citywide rate at 6.07. And note that these inequities can't be explained by individual level factors, such as behavior or biological factors, but rather social and structural factors that influence outcomes in health outcomes in our society, such as institutional racism, access to quality health care, as well as education and employment. And then we can also think about the role of stigma, as well as both historical and current mistrust of healthcare institutions. Next slide, please. So if you just give it the prompt, great, thank you. So what you're seeing here are the numbers of congenital syphilis, right? In green, the green bars, plotted against that case rate per 100,000 in women, so that we can really visualize how the rates that are increasing also correspond to increasing case numbers of congenital syphilis. So these are cases of syphilis where the pregnant person passes the infection to their fetus. In green, what you see are the case numbers of live born, so infants born with congenital syphilis. The red bars indicate a case where the infant was a stillbirth. And so contextualizing all this further, even though these numbers may seem relatively small, even one case is entirely preventable. And of concern is that these cases are increasing, and the rate is increasing among women, and we're seeing it much more dramatically with Black and Latinas women. Next slide, please. So again, this is all in the report, but I just wanted to highlight some of the tables that kind of outline the reported early, primary, secondary, and latent case numbers, so that you can just appreciate how when you look not just across boroughs, but even within boroughs, where there are inequities. So what we're seeing here in the Bronx is that the rate for women is almost 30. When you look further down, and I highlighted in yellow, we see that Hunts Point, Mott Haven has a dramatically higher case rate for women compared to that borough's rate. Next slide, please. Similarly, what we're seeing in Brooklyn, so that case rate for women is 13, but when you look at, for instance, East Flatbush and East New York and East Flatbush, you're seeing, again, almost close to a double in that case rate compared to the case rate of the borough. Similarly, in Manhattan, we have for women almost an 11 per 100,000 case rate. When we look at East Harlem, that's almost 3 times that rate. Next slide, please. For Queens, we're seeing that the case rate for women in the borough is about 11, but then we're seeing over double that in Jamaica within the borough. And finally, taking a look at Staten Island, which has the lowest case rate across the board and also for women. But when you look at Port Richmond, that has almost 3 times the case rate for women in the borough. So what I'm hoping you all appreciate is that sometimes it's not just enough to look at the overall numbers, but really to look across boroughs and within and really see where those inequities lie. Next slide, please. So one of the things that the New York City Department of Health and Mental Hygiene is doing, and there are several programs and services that the health department offers, but here's one project that we are implementing to address this. We designed an equitable process, and so you see a conceptual design of this project, where we're hoping to promote active and meaningful community involvement in the development of a plan to reduce syphilis. And we're doing this by utilizing 4 guiding principles that are woven throughout and include outreach, consultation, involvement, collaboration, and shared leadership with community throughout the project cycle. So we are conducting activities related to outreach, education to increase awareness, sharing resources and information. We're also looking to consult with community members. So we are embarking on a couple of different needs assessment activities where we're seeking feedback from community members so that we can identify needs and assets, as well as set priorities and support decision-making. We're hoping to collaborate by supporting the involvement of community and stakeholders in a work group to develop the syphilis reduction plan that prioritizes the needs of Black and Latina women in these neighborhoods that are most impacted. And hopefully by the end of this process, there'll be shared leadership where we are really working in conjunction with and having community tell us as the health department what are some of the things that they're seeing on the ground and that they think would be strategies to move forward to reverse this trend. Next slide, please. So I'm going to go through a little bit more in detail about the 2 different phases of the project. One is really to, again, identify and invite key stakeholders for participation and partnership in this project. And we've been doing this since the end of last year. We're also in the process of performing a mixed method formative assessment. As I mentioned earlier, we really want to hear from community members persons of lived experience, both clinical and non-clinical providers that work with the prioritized population. What are the needs? What are the strengths? What are some facilitators as well as barriers to accessing care, prevention, treatment, and intervention? And as part of this needs assessment phase, we actually have launched a community needs assessment survey. Participants are offered $40 e-gift cards to take the survey. We're also going to be holding 2 focus groups. Participants will also be offered $40 for participation, as well as key informant interviews. The key informant interviews, again, are for both clinical and non-clinical providers that offer services to the prioritized population. Next slide, please. And then with the second phase of the project, which we're hoping to start by the end of this month, early May, we are hoping to convene a work group of up to 38 community members and support a series of 12 meetings where the work group will be able to prioritize community goals and strategies for syphilis and congenital syphilis reduction, again, focused on the prioritized population of Black and Latina cisgender women. Work group members will be offered a $50 e-gift card for each meeting that they attend. And the outcome, the overall outcome of this meeting is that a community-driven syphilis reduction plan will be drafted and will really call to action the health department as well as other partners such as community-based organizations, faith-based leaders, and what we can all do in conjunction to, again, reverse this trend for the prioritized population. We've already started to see some challenges emerge. One thing that I can share with while I've started to collect this data and begin this process is that there are competing priorities that community members are facing. And that is something that we need to take into account, where housing, food, employment might take priority over sexual health and reproductive health. Another challenge that has come up is that overall, from what I'm seeing, and I'm sure you all are not surprised, is that there's relatively low awareness of this, not just among community members, but actually among providers, both clinical and non-clinical, not really understanding that these are important epidemiological statistics that are showing that syphilis is on the rise, that it's not something from the past, it's not something that you need to test for, etc. Oh, sorry, next slide, please. Those are the challenges. And next slide, please. And I just kind of wanted to share this, and again, this is in the report where you can see that these are pie charts that show you the case investigations and partner services that were conducted for syphilis in 2022. What you're seeing is that on the left, like the majority, almost 90% of case investigation did occur within 14 days. So that's really important so that folks are getting treatment and they're getting timely treatment. But there's still about a little over 10% of those investigations that are not being completed within those suggested 14 days. And we'd like to narrow that down. Similarly, on the right, what you're seeing are the investigations that resulted in, the completed investigations that resulted in the case actually found to be a case. Which is about half, versus those that were found not to be a case. So again, thinking about what those implications are for providers that are testing, that are offering treatment, and those disease intervention specialists that are on the ground working with diagnosed cases. And then what you're seeing on the furthest right are those interviews among women that were actually completed, which again, the majority are, but there's still about 15% where the interview was not completed. And things that have been emerging, again, this is through the process of starting to conduct the needs assessment. I'm sure it's not going to be a surprise. Folks have mistrust. They may not understand why the health department is contacting them. They may have heard something different from their provider related to the diagnosis. So these are all things that we need to consider as we move forward. And I think I went over this one already. So, this is actually, again, I should have had this earlier, but just so that you can appreciate that even though, again, those case numbers or the rates seem low compared to men, we are starting to see that there is like that slow but steady increase among the rates for women. And these have obvious implications for persons that are either considering becoming pregnant or are pregnant or even have the potential of becoming pregnant. And I believe that I'm at the end. So I thank you all, and I look forward to, if you're interested in learning more, here is a link. You can also reach out to me, and I believe my contact info is there. Thank you so much.
We'll switch with you. I will say this is the weirdest experience of my life. Can you hear me, everybody? Okay, because I'm kind of loud. Since we have extra time, I'm going to do something that Priya suggested. My name is Dawn Schuk, and I am CEO, Executive Director of Sisterlink. But I'm going to tell you a little bit about Sisterlink before I get into my slides. Sisterlink was started by the AIDS Institute in 1999 to combat perinatal transmission in certain neighborhoods. What the AIDS Institute decided to do was, instead of creating a program to provide services, they created a program that was a network. So what you did was you built a network of organizations, both medical, supportive, housing, whatever you can get to make a broad-based network to connect these women to early prenatal care. They built the whole program around HIV positive pregnant women. They met with them. They developed pretty much everything from the ground up, the model based on the women's input. So what it was determined is that we would be the link in the chain. So instead of providing the services, we would actually get you connected by building relationships with people in the neighborhood. I happen to have started in 2005 running the Northern Manhattan Perinatal Partnership, CAPSI, which was named Sisterlink. As the years went on, it became very obvious to the AIDS Institute and to us that these HIV positive women had co-occurring issues. It wasn't just about being HIV positive. Some of them had substance use issues. Some of them had mental health issues. Of course, housing in the city is always an issue. There was food insecurity. So as the program started to develop, it moved away from its original mission, and the AIDS Institute could no longer justify funding it. That ended in 2013. Because the model was so good, I asked if I could turn it into its own nonprofit. I took the name and I created Sisterlink Collaborative Inc. I won't lie, I'm going to tell you the truth. I got very far away from pregnant women because the model itself can work with any high risk people. It's really about working with people, connecting people to people, having 4 or 5 trainings a year based on what our outreach workers are telling us they're seeing. It's consistent quality improvement. So we're always looking at what we're doing to be better, but not necessarily be perfect. I moved away and started working in human trafficking and developed for veterans. And then somewhere in the last year, I ended up on a statewide committee for congenital syphilis. I did not recognize that it was that serious of an issue, but it does bring us back to our original mission. Now, the Sisterlink network is very broad-based. It includes faith-based organizations, it includes CUNY, it includes medical professionals, it includes supportive services, anything that pretty much we could connect to, we're going to develop a relationship with. But again, it's a person to person. So it's not about going out and giving someone a flyer and saying you can go here to get services. It's about how we train 3 or 4 people at Helen B on 116th Street, so that if we navigated somebody there, they could ask for the specific person, and there was a person-to-person contact. A lot of times, high-risk individuals with co-occurring issues may be scared away from getting any kind of early prenatal care or any kind of medical care based on things that may have been said to them at the facility. And we work hard to work with the medical professionals and anybody else on training. I can say we do workshops on no judgment. We'd like you to have no judgment. Unfortunately, there are people who will always have some judgment when it comes to clients, which is why we're always in. If I get 3 complaints from a client about a facility, the next I'm having a meeting with everybody and we're finding out what's going on, because I do not want women to show up at the emergency room with no treatment, either for syphilis, no treatment for HIV. I don't want anybody to be at risk. So that's when I talk about the network. It's a living, breathing thing. You're always looking for new organizations to be a part of. You may hear of, a food pantry that you didn't know. You may. I'm not really good at standing behind things, in case anybody noticed. I'm a mover. So that's what I mean by a living, breathing thing. It could be as simple as knowing even the supermarket in your neighborhood, because maybe at the end of the month they give away stuff or whatever you can have for clients. Another thing I always say is very important, and the AIDS Institute was dead set on making sure we had these Metro cards. So whenever I'm looking for funding, I'm always looking to have Metro cards, because it's not an incentive, it's a necessity. And if I want someone to be able to get to appointments, I need to make sure they have Metro cards. We do also try to make sure we'll have diapers and other things for clients, but really it's about getting them connected to people immediately. And what everybody could do is start working together. I know that sounds like everybody says that, yes, but what I've noticed over my 35 years of working in nonprofit is people get stuck in their silos. This is my population, this is who I work with. And yeah, I'm being told to move on, I'm moving on. No, so that's what I want you to do. Next slide. So that's basically what we are, a resource and referral network. Again, I don't judge. If you are pregnant and you have a substance use problem, then I'm making sure you're getting prenatal care and you're connected to one of our harm reduction programs. It's not about telling you you have to do X, Y, Z. It's about having positive birth outcomes. We want both positive health outcome for mother and we want positive health outcome for baby. Next slide. So you can join Sisterlink. It's a free network. I don't charge anybody. And then what happens is we have quarterly meetings. This is how we communicate on what's going on, boots on the ground. And also it's how people give feedback so we know how to adjust. Maybe there's a neighborhood we haven't targeted yet. Maybe there's a new laundromat we could be doing outreach at, so that we're always communicating. There's formal communication, which is meetings and agendas, and there's informal communication where sometimes I show up at an agency with donuts and coffee and then get everybody relaxed and get the real info. Next slide. So we know that there are resources, 311 and 988 here in the city. They're good for what they're good for. I'm not going to say yes or no, but the reality is that if you're in a community or you're a CBO in a community, you could create your own resources just by walking around your neighborhood and noticing a lot of urgent care facilities that people may be utilizing. Or again, nail salons may have a lot of women that can give you information about what's going on in the community, or maybe heard of a new place to get food. The overall goal for me, from my perspective, is to make sure that everybody in the city knows what resources are available for them. Men, women, children, over 65, under 65, because the resources are no good if people aren't utilizing them. And if I have my way, everybody will have housing and health insurance in this country before I die. Next slide. So this is my information. Please feel free to contact me anytime. I'm slowly rebuilding the network here in Harlem. I do also want to target Brownsville. That is important to me. But yes, I will be looking to have other meetings and set up committees, so please reach out to me or to Priya or to Deborah or the doctor, and I really would like to start getting this moving in the next 2 months. And with that, I'm gonna stop doing that. And if there's any questions, we're here. Oh, got you.
Thank you to Don and Dr. Betancourt for your presentations. We have quite a few questions. First off, let's start with, can you ask to be tested for syphilis? And if you get syphilis, should you tell anyone?
Wanna go first?
No, I'm gonna let you go with that.
So break it, start again. Can you ask?
Can you ask to be tested for syphilis? And if you get syphilis, should you tell anyone?
Okay, so my first answer to that is yes, you can ask your provider to run a test. And if for whatever reason a provider is saying no, oh, sorry, consider finding another provider. I can also appreciate that insurance, that might always be a rigmarole, but there are sexual health clinics that are run by the New York City Department of Health and Mental Hygiene, where you can get tested, not just for syphilis, but all STIs, including HIV, and those services are available for free. So that's one. The second is usually what happens is that when you are diagnosed with syphilis, what's called a disease intervention specialist, or there's different titles, but someone will be in touch with you, because what's also important is not thinking about this, not just that you are getting treatment and effective treatment, that anyone that may have been exposed, meaning that they may also have syphilis in your sexual network. So other partners that you've had, that they get treatment and tested as well.
I would piggyback right on that. There's sexual health clinic right here in Harlem. There's one in Chelsea. There's also Planned Parenthoods, which do things on a sliding scale. It's a similar kind of thing. If you test positive, Planned Parenthood's going to report it also to the Department of Health. So you will someone will get in touch with you. But I will say this: if you haven't had multiple sexual partners and it's been one partner, I suggest having that conversation with that partner beforehand, so everybody can get treated. We were very big at Planned Parenthood on treating everybody. If you came in, like you, the person they treated, like just to make sure. So you don't have to shout it from the rooftops, but at least the person that you're sexually active with, you should have the communication with.
And I would just so this is not me taking off my health department hat and going back to, because I was also at Planned Parenthood and did a lot of direct services. Also use your best judgment. If for whatever reason you think that a partner may not respond well, or you don't know, maybe like it was not a partner that you normally have. Like, again, that's something that through disease intervention services, that person will reach out without disclosing any of your personal information to that partner.
Yeah, they basically tell you that someone from your past sexual history tested positive for something and you should get tested. I used to have to do that.
Yeah. and like if you're on the younger side, there's also other organizations that, like Mount Sinai Adolescent Health Center, The Door. These are places that, I think are also great for primary care and all sorts of things. So
A follow-up question, is congenital syphilis curable?
Yes. Hence the reason why we want you to get treated. So that it doesn't have to be congenital syphilis either. We can get before them, but yes, the importance to understand about syphilis is it can be treated. It's not HIV, it's not long-term medication, it's a shot. And the sooner we get it to you, the better. That's really what it comes down to.
Yeah, I agree. And I think that that's a key thing, like the sooner the better. But keep in mind that, yes, it's a bacterial infection. And unlike, for instance, HIV, which is viral, it does respond to antibiotics. So the sooner the better, because the longer with the infection there are, the higher the chances of negative outcomes.
How can we raise awareness of congenital syphilis with providers?
The challenge. Well, I usually use peer-to-peer. So I'll have a physician maybe who works within a facility, do a workshop. Doctors like webinars, they like Zoom, so they don't have to leave. I like the in-person touch. But peer-to-peer usually works for me. It's not going to be, some doctors are going to jump right in and be, yes, let's do this. Some doctors are going to give you some kind of shtick about this and the insurance, whatever. It's a matter of consistency. So again, you invite them to things, you refer clients to them and you get feedback so you know what's happening. So you know if you have to go in again and work with the staff and with the doctor, you know, I would like to say every doctor is going to do it. It's going to be a consistent thing, constantly keeping up. Again, though, most doctors are testing for it. They are. When you're coming in for a full lab panel, they're testing just to be sure. But it's always, it helps to ask, to work. If you're working with health providers, ask them if, you know, a 20-year-old young woman of color comes in and she's 6 weeks pregnant. Are you doing a full STI screening on her? You ask them, and then you start working with them on how they could incorporate this in. And you also empower your community when they go to the doctor to tell the doctor, this is what I'm here for. This is what I need to be tested for. I always explain to patients that that is your time when you're in the room with the doctor. And I know that they book 3 patients every 15 minutes, but it's still your time. So you can write down your questions beforehand and just pull it out when you're there and say, these are the things I need today. And you have to take a little bit back from you. But overall, I would say that once you talk to providers, a lot of them will get on board because no one wants to see these numbers. No one wants to live in a state where 69% of women of color are dying or their kids are dying, and it was 80% preventable. That kind of data you want in a positive way. Like I want to say I got 69% women tested and treated and 80% were cured. I don't want to see it the other way. But again, it all comes down to communication and the way you see that. That's what it comes down to.
And I agree. And I want to piggyback off of that because I also think that, you know, again, like our lives hopefully are long and healthy, right? And for folks that have pregnancy potential, it's not just about that time period where you could possibly get pregnant or are pregnant, right? So I think like part of this is not just the intervention when there is a case, but preventing a case. And so I think, and this comes up quite often with a number of sexual and reproductive health issues where providers may be like, well, I didn't test this person, or you don't need to get that, you know. And so I think in part, I agree, like community and community-based organizations really having their constituents, like the folks that they work with, know their rights, feeling empowered to ask their provider for what they want, and knowing where to go if that particular provider is not meeting their needs.
Can you get syphilis more than once, even after receiving treatment?
Yes.
Yeah. Please don't. Once you do,
Yes.
please encourage all your clients and everybody else to wrap it up and to not try to get it a second time.
So like think about the, like maybe this is a really general way to think of it, but it's a bacterial infection. So you like with anything, you can get treatment, it's cured, but then if there's another exposure, you can get it.
We have a couple of questions about the survey. So how old should you be to participate in the survey, and who should be part of the city survey? I know we can send some of this information out in the follow-up email, but for attendees right now.
At the moment, we're looking for folks that are 18 and over for the survey. However, for focus groups, we are thinking about as young as 16. And there's no age, upper age limit.
We have another question for Dr. Betancourt. And Don, if you also want to chime in here, why are Black women's rates of maternal mortality rates so high?
I'd love to hear from community for folks. I know it's difficult because it's virtual. I will say that quite often with public health, we overlook the reality of social and structural factors influencing health outcomes. And so as opposed to like any individual level behaviors or a particular community level behavior, it's really about the structure. So the US and New York City, as wealthy as it is, does not adequately resource Black communities, Latino communities, and often within those communities, women are not, again, being elevated, their voices and their needs are not being attended to. And so I think all these different factors play into what we see, not just with, in this case with syphilis, but with other health outcomes.
Yes, I'm not going to be as politically correct, but the unfortunate thing is in America, women as a whole are discounted when they talk about healthcare or how they're feeling. Women of color are discounted even more. And having worked in these communities for a long time, it's a twofold thing. Some women will go and, you know, not feel like they're getting what they need out of it and not communicate. Others just don't go because they don't like being judged or being told that they're not doing something the right way. Or they did feel like they were trying to convey what was going on and no one was listening to them. I will say that, again, these are things that a bunch of us are trying to work on because we should not be seeing these numbers. We shouldn't see the high rates of infant mortality. You're right, it's not just syphilis, it's mental health, it's substance abuse, it's the domestically violent relationships, because there's all kinds of co-occurring issues within the community that need to be addressed, as well as addressing someone's health, medical health, sexual health. It just is disconcerting that women of color can be so disregarded, and oftentimes by a doctor of color. So that is something we could all work on together. But this is why you're seeing rates like that, is that either they're not going for care or they've gone and they didn't feel that they were getting care.
On that note, can you talk about the role of doulas and birthing navigators in helping women to advocate for care? Also, can you speak about the roles of birthing centers and how we can get those into our community?
Does Harlem Hospital still have their birthing center? Yes. Harlem Hospital has a birthing center. It's been here for a long time, I believe, because that was my old CEO's long time ago. Doulas, midwives, everybody. It's the, I don't want to call it like the soul part of healthcare, but doulas, midwives, they bring the more connected part of healthcare. Instead of just going to see a doctor who talks to you for 15 minutes, says, this is your blood pressure, this is how you're feeling today, Dawn, blah, blah, blah. Oh, is the baby moving? We heard a heartbeat. Doulas bring in more of that spiritual and the soulful part of a pregnancy, but also can empower you by educating you on what to ask the doctor. Pregnancy is a long time and it's a complicated thing, and every pregnancy is different. So it is very important. Doulas, midwives, they bring in that connection that you don't necessarily always get in a medical setting. If the hospitals in your area don't have birthing centers, I would start communicating with them to figure out how we can create. Northern Manhattan has the doula training program where they're training doulas. again, for someone like me, I think that it's only an extra added benefit for a woman who's pregnant to have someone who's there to help support you consistently and help you engage the medical professionals. You have any?
No, just to add that the health department does have the citywide doula initiative. So that's also a resource for folks. And I actually was just meeting with some of their team members yesterday. So out of their Brooklyn District Public Health Office location.
Thank you. Another quick question about the survey. Do I have to be a cisgender woman to participate in the city survey or the program?
No, so for the survey itself, eligibility is that you are 18 and older and that you live in New York City. To be a work group member, so we are prioritizing folks that are Black and Latina cisgender women living in the neighborhoods that we're working with. So that is Harlem in Manhattan, the South Bronx, including Hunts Point and Morrisania, Brownsville and East New York in Brooklyn, Jamaica and Queens, as well as folks that are providers, either clinical or non-clinical providers or advocates and activists that work with that prioritized population. That's for the work group.
Thank you. Another question just came in. We don't have a birthing center in Brooklyn. How do we advocate for one?
Well, I'd say start with one of the hospitals there and maybe reaching out to their maternal child health department and talking to the head OBGYN and talking about how a birthing center can be beneficial for them. Brooklyn, of course, being one of those areas that has high rates. But it could be also the kind of thing you could talk to your local city council person as well and bring them into the fold and have them set up a meeting. If you don't think you can set up a meeting, you could also reach out to the Department of Health to start talking about this. The idea is collaboration is how you get it done. Bringing a few people to the table and then developing something and going and giving data and explaining why this would be good for the hospital. From an administrator perspective, they're going to look at the bottom line. There's a bottom line for them. They will be able to bill insurance. They will be able to, but the other thing is it creates something in the community where people having positive experiences there will start to talk about it and more people will start to utilize it. And that's what we want. Word of mouth is the best asset I have. If someone has a bad experience, that spreads like wildfire. Somebody has a good experience, that also spreads like wildfire, and more people are apt to utilize a facility. So I would say start there. Which hospital you think it would be best is the most accessible. Accessibility is important, which would be most receptive. And starting to figure out, again, you could reach out to both of us. We could start seeing how we can navigate it. And, I'd drag in Deborah and Priya anytime for everything. So something of that nature. It's, but start, just start, pick a hospital and then take it from there.
And I would say also along with that, consider like community board meetings, get on their agenda, start to get that aspect as well in place.
Don't underestimate your community board. I learned from teaching school the last few years that community boards do a lot more than I thought.
Yeah.
And it's a good place to start because they have a lot of say in your community.
Thank you. Another question that's popped up is what role does education play in preventing congenital syphilis? And how can we ensure the accurate information is reaching those who need it the most?
I was going to say social media. Honestly, the best, so I did a little focus group with some of my friends' kids who are between 14 and 18. Where can I target them for this information? TikTok. They said, create a little TikTok, do your little 2 minutes of your giving information. They're more likely to ingest it. But the education has to be appropriate for their population. And when I say that, I mean in language that they speak, not like language that we would communicate with each other, but some slang if you want to throw it in so they understand. And even if it's possible to utilize a youth to do it, but education also could just be like walking around and you see people out and you see them in an area all the time and you just start talking to them one day. You don't throw everything down their throats. You just kind of start talking to people. You say, "What this is what we do. We give out condoms everywhere," that kind of stuff. And you start communicating and then you educate that way. But again, everything should be language appropriate, cultural appropriate, age appropriate, so that they're getting the information properly. And social media seems to be the place that it's happening now.
Yeah, and I would just add that I think it's also important, like when you're considering like those communities and those individuals within communities that might need it the most. Again, like it's not a one size fits all. So really understanding like what would it mean to develop culturally responsive education messaging, and then thinking about that you're not just getting education from one source, right? So having multi-pronged approaches to really raising awareness. So what's going on in schools, like what's going on in social media, like what is available to you in your community, libraries even, you know, all these different places can be sources of education and awareness and messaging.
Thank you both. Our last question, which I think will be a great focus for our takeaways, how do we get this information out to our community boards, to our community members, and looking ahead, what are the key priorities and goals for addressing congenital syphilis in New York? How can stakeholders collaborate to achieve these goals?
Come to our meetings.
Yeah, I would say definitely join organizations like Sisterlink. Again, like consider going and bringing these issues up in your community board meetings. Notify your city council representatives. I would say consider reaching out to me to be a member of the work group. Like it's a very small piece of this, because I do think that it takes many different sorts of like interventions, but join, there's a host of sexual and reproductive health advocacy groups that are in the city. Consider that.
And if you're looking for a list of your community boards, New York City is pretty organized that way. So if you just put in Google New York City community boards, it will list every community board, who's in charge. It'll take you to their website. It'll tell you how to contact them. Does the same thing for the city council. And to be honest, it's how I started establishing relationships, and people have been pretty responsive. Like I just, you know, this is what I'm doing, and if you're interested. And so I would start that way. Community board meetings run all the time, different committees for different things that maybe you can show up for. Usually Tuesday or Thursday nights seems to be the nights that they have them. But yeah, everything will be listed on the website. And if you start going, or even if you reach out to the person who's organizing the meeting and you can get a few minutes to talk, they'll give it to you if they have enough notice. That's how you start. And it could be as simple as, again, looking at other CBOs in your community and collaborating together. Sadly, there's going to be enough clients for everybody, and one size shouldn't fit all. If I have a client who isn't comfortable at one place, I refer them to another place. No judgment, no anything. There's plenty of places, and that's something that you need to accept also as a CBO or a facility. So,
and I would just add, and maybe it's a shameless plug, but a great place to start is right here. So there's a sexual reproductive health justice hub, and really, I think all of us agree that like it's not just about particular health outcomes for particular conditions, but that this really is a social justice issue. So I would say start right here. Thank you.
thank you.
Thank you very much to the two of you. Both have given us a lot to think about. I would say that if there was a takeaway here, it's about advocacy. It's about raising your voice. It's about collaboration, and it is definitely intergenerational because we all have a place in this work. So next slide. As always, I would not be remiss if I didn't thank you all for joining us in Zoom land and here. I want to thank both of our presenters today for giving us not only the data, but recommendations about how we should move forward. We also would like to acknowledge the fact that we recognize that sexual reproductive justice work is not just around contraceptives, but it is also about body autonomy, and part of congenital syphilis, part of healthcare, part of the advocacy all stems from us having a collaborative voice. So on behalf of the School of Public Health and Health Policy, we thank you. Again, we thank our partners because we would not be here without you all, and the continued support. Again, even if the poll is closed, we have a poll coming up. So please make sure that you're answering the poll by either clicking on the QR code to get the poll to come up, or you'll see it come across your screen. Just really quickly, as we're closing out, we have some events that are coming up here at the School of Public Health and Health Policy. We are launching or have launched our Cannabis Corner Equity Series. Our next one is tomorrow, actually, on the cannabis history and practice access across the industries, which is really looking at non-touching flower roles of employment through public health and where we need to be from a medical perspective and a research and public health perspective. So we're super excited for that conversation. Saturday, it's 420 for those that don't know, here in Harlem. The school will be joining the Manhattan Community Board 10 for the 3rd annual Higher Learning Cannabis Conference, which is right out in the street, and we will have panels. The Office of Cannabis Management will be there, along with some of the dispensary owners, to talk about what it means to have a dispensary in a community, and also we'll be raising the conversation around illicit shops and how we as a community can work to ensure that they are shut down so that we can ensure that our legal shops are able to operate in a way that will allow them to have a successful business. May 1st, I'm happy to announce Tackling Anxiety and Depression, the State of Mental Health in Harlem. This is going to be a really special webinar. It is in collaboration with community boards 9, 10, 11, 12, and 100 Black men, and it is being hosted and sponsored by the Harlem Hospital Center's CAB, which is probably the first, but we're super excited to participate in this process. Padmore John from the Department of Health will be helping us center the data, and Dr. Sharif, who heads up the behavioral health at Harlem Hospital, is going to give us a detailed outline of all of the outpatient services at Harlem Hospital for behavioral health. How do you access them? What do you need? What to expect? What is anxiety and depression? So this is going to be a great conversation, and we're looking forward to this. And we're also happy to present that the School of Public Health will be launching its first blood drive, responding to the New York City request for blood since we are entering the summer and there is a shortage. That will be on May 9th. It will be in person on the ground floor at 55 West 125th Street. Stay tuned for additional details because we will be sending out the link for how to participate in the blood drive. So we ask you all, if you can't give blood, please send this on to somebody who can, because your donation can not only save one life, but several. Last but not least, we have our Community Health Equity Bulletin. You see that there is a QR code Please, if you want to follow us to find out about upcoming events, how to register, please make sure that you give us, follow up with us in that way. We also have, and we are on social media. So please, I'm going to ask everybody who's in Zoom land to take your phone out and link with us both on Facebook, Instagram, LinkedIn, and you can also follow us at the Harlem Health at SPH.CUNY.edu. That's it. Priya said it's time for us to go. So thank you again for all of our participants. Thank you again for our panelists, but most of all, thank you all for all of you, the work that you do for our community and creating those safe spaces. Thank you, and we will see you soon.